Hello, welcome to another session of ICAAC Live, coming to you from San Francisco. ICAAC is the annual infectious diseases meeting of the American Society for Microbiology, or ASM. And I'm your host at some of these sessions, Jeffrey Fox, the features editor of Microbe, the monthly magazine of ASM. For those of you who are watching and listening over the internet, if you would like to ask a question, we invite you to do so using hashtag ICAAC or the @ ASM Newsroom. In this session, my guest is Suzanne Geerlings, whose name I don't think I pronounced properly, who is from the Academic Medical Center in Amsterdam in the Netherlands, and she's going to be talking about cranberries and whether they prevent urinary tract infections. And if you would like to start with a brief summary of your work and the highlights, and then we can have a conversation about some of the details.
Okay, thank you very much. We did two trials. One was performed in premenopausal women, and we compared in women who had a history of recurrent urinary tract infections, so that means at least 3 per year. But they had an mean incidence of 7 per year, so it was a very severe group. And we compared a standard prophylaxis method, which was low-dose antibiotic prophylaxis, 3-metoprim sulfamethoxazole 1 time 480 milligram daily, with 2 times daily cranberry capsules. And it was a double-blind design, so during 1 year they didn't know what they were taking. And as one of the endpoints, we measured the incidence of UTIs, and at the other endpoint was the development of resistance of the normal bowel flora. So that was the design, and what we found was that the cranberry capsules were less effective than the low-dose antibiotic prophylaxis. So during the follow-up of 1 year, the mean incidence of urinary tract infection was 4 in the cranberry group, compared with 1.8 in the low-dose antibiotic group. So that was the effectiveness, but we also looked to the resistance, and we collected each month's feces and urine from the women. And when we looked at the feces, what is your normal flora, we saw that the resistance against, of course, the 3-metoprim sulfamethoxazole, but also against other antibiotics like amoxicillin, was increasing after 1 month immediately. And it took at least 3 months after stopping the antibiotic prophylaxis to go back to the baseline resistance. So cranberries are much less effective, but then in that group there was no resistance development. So you have to a little bit weigh pro and cons what you want to take as a patient.
I see, and you don't have a specific recommendation about what way a woman what she should choose.
No, it depends on the burden of the disease. If you think it is so bad for me to have a UTI, I really don't want to have it next year. Now you never know, but then you must take the antibiotic. But it was very difficult to perform this trial because all women asked me before, can I get in the non-antibiotic arm? They didn't want to have to be randomized because women know that if they take antibiotic for a long period, they will have resistant microorganisms, and when they develop a symptomatic infection, they also know that it is more difficult to treat it. So, no, it is not so easy.
I see. So, can you say something about the, you've said that you used cranberry capsules, and I'm not quite sure that, usually people drink cranberry juice or eat the fruit as it's been cooked in some fashion, but I gather you did this in part to mask what they were taking, but also to have a more uniform dose.
Yes.
So can you describe that a bit more fully so we know what you're doing? And is this just a dose? You didn't get the dose right. If you had used more, a stronger concoction of cranberry concentrate, it might have worked better.
Now, one of the biggest issues in all the research about cranberries is that we don't know the exact dose. We even don't know exactly the working mechanism. We think that it is a certain substance called proanthocyanidine, but we don't know exactly which dose is needed to really have a lower incidence. And there is a dose-finding study at this moment, but it's already for many years is still underway. So that's a little bit a strange situation. You start with study without knowing the right dose. Now, what we know that it is, if you take the drink, it must be very concentrated. And it's not very nice to take a long drink every day with a very so the adherence is more difficult. So that is the reason we choose the capsules and also to give it in a uniform way and also to blind it.
Yes.
But we measured afterwards the dose of the proanthocyanidine in our batch of capsules. And we think it was low. So, because in the meantime, in the few years that we performed the study, there was also an in vitro study from France, and they said, we will recommend a higher dose than you used. But nobody, that is also an in vitro study, and we must wait for the clinical dose-finding study to really know it.
And what do you mean by an in vitro study? Not an animal study, but
no,
something
in a petri dish?
No,
it was more an ex vivo study. So they gave cranberry substances to patients, isolated the urine and looked to the concentration, and also isolated what was the anti-adherence activity of the urine of the patients. And they saw if you had a higher dose, it took longer, and it was the maximum of 6 hours after ingestion of the cranberry substances. So it's a little bit an indirect way to measure activity.
Okay.
And then the recommendation followed that it had to be, 72 milligram of proanthocyanidine, but what was very effective. And to give an idea, we had 9 in our study, so much lower.
Much lower.
But there's only one study. I think we must wait for the dose-finding study to really know these results.
Now, cranberry juice and cranberry products have been talked about for many years, maybe several decades at least, as a promising treatment, kind of a natural treatment for urinary tract infections. And you're talking about only one ingredient as being the active ingredient here, but isn't it a pretty complicated product with multiple chemicals in it that might have ancillary activities, or is it so straightforward that it's one principal active ingredient?
No, it's not so straightforward. We don't know, if I'm honest. So what has been shown is that one ingredient I mentioned, that the microorganisms which have to adhere to the cells in humans, that they can be inhibited, the adherence can be inhibited as a result of that ingredient. But maybe it's much more in the cranberry, and it is also much more the combination of ingredients in the cranberry. And another problem is that we don't know exactly what's happening when you take it by mouth, and then it's going to your gastrointestinal tract, and before it's in your urine, it has passed a very long way. So what's happening there and in the meantime? So there are many, many questions. That's always what scientists say. More research has to be done. I'm sorry, but that's also correct for this one.
Well, we want to make sure we get it right, not oversimplify the question. And I mean, so it seems to me that makes a big difference in terms of trying to determine what dose to use. If you have multiple ingredients, your cranberries might vary from one batch to the next. And so you might have, you might work one time and not another, for example, right? So I think I would like, you didn't say about the size, the number of people in the study, and
yes,
that some of the other parameters, it might be helpful to say how many people were involved.
221 women, and they were randomized equally to the two groups, 110, 111. Yeah.
Okay, so it's a pretty substantial group of people.
And that are the premenopausal women.
Premenopausal, so young.
Yeah.
What's the age range roughly?
Yes, between 30 and 40, but we had one big problem, and it was also that it was a very long intervention period of 1 year, and the women did not know what they were taken. So after a few months, we had a large dropout. And we analyzed it, and we looked that there was more dropout in the cranberry group afterwards than in the antibiotic group. So in our analysis, we correct for selective dropouts.
I see. So when you say, does that throw off your statistics, or you're correcting for it?
No, we have correct for that. We first did a rough analysis, and then the results were different. And then we looked to the data, and we also analyzed it blinded, because you have believers and no believers. And then we said we have to correct for the selective dropout in one group. And afterwards, it seemed the cranberry group, after the analyzing. So I really believe that the adjustment was very good for this selective dropout.
Okay, and nobody can accuse you of having a placebo effect here, because you have a drug group and a cranberry group, so everybody got something as a treatment. So that's a plus. So where do you go next with these findings? And it does. I mean, I ask that very pointedly because this issue has been simmering for so many years, and it never quite seems to be resolved. Everybody keeps saying that cranberry juice probably works, but here the results are a little bit disappointing, but not exactly negative.
No, it's a little bit, you can compare it a little bit with all the other studies which are summarized in the Cochrane review, which show that you have a small reduction in the incidence, especially in the younger women. And in our women, we had a background incidence of 7 per year, and they went to 4. So it's a little bit the same reduction. But of course, that was not our primary study aim. We asked back for the number of UTIs per year. So we didn't measure it ourselves. So that can lead to a little bit bias. But I think what we can say now, you can discuss it with the patient and say it's not a golden bullet, not at all. But there are also not many side effects. There are some interaction with other medicine, for example, against oral anticoagulantia. You can have an increased bleeding risk, warfarin, etc.
Yes.
But you must discuss it with your doctor, and then now you have pro and cons, because the lack of resistance development is, of course, a pro. But it's not a golden bullet. And everybody is always asking me about the cranberries, but we did another trial. I think that's more, we'll have more future about the lactobacilli. And I think we have more to go in that way. So more the probiotic way. So not the cranberries only.
I see. So you would look for a combination in which women, primarily women, would be having concentrated cranberry as a capsule, and they would also be using a probiotic and what?
Yes,
consuming that as a food, or?
Yes, that is the other trial. But now, to end the cranberry discussions, it is not no or yes, but it is not the golden bullet. So we have to go on with other interventions, other non-antibiotic interventions. So that's what I want to do in research, looking for other ones. And the one we did was an oral capsule with 2 lactobacilli strains.
Okay.
That was another trial. And there's also performed another trial by other investigators, and it was a vaginal lactobacillus strain. And I think they are very promising, these results. So we have moved a little bit away from the cranberries to other non-antibiotic interventions.
I see. And would you anticipate that combining cranberry and lactobacilli probiotics would be a plus, would be synergistic, or would they interfere with one another? Or?
No, if you think about the pathogenesis, the first one, the lactobacilli, helps in the colonization step, and the second one in the adherence step, the cranberry. So it's not antagonism. I think maybe it's a good idea to to make a combination.
Okay, and then, but of course, if you talk about cranberry by mouth as being a long, circuitous route to where it needs to go, that would be true, even truer for the lactobacillus, would it not?
Yes, what we found was very strange because we used 2 strains which were investigated before, and we make the choice for those strains because they could reach the vagina, so through the mouth the whole way. So we thought that's a very interesting one, but we couldn't find them during the trial there.
You couldn't find them?
No, we found them in the bowel. So we developed a PCR, and we could measure them in the bowel. So we knew the women were taking it, so 90% of all women were taking it. But we could not confirm the early studies that they reached the vagina. So that makes it difficult to explain the results. So I think there's some reset.
Some sort of nearest neighbor phenomenon.
Yeah.
Said it? Okay. That's not a very, I mean, you have a delivery problem, I guess, in both cases. And I'm not quite sure how you overcome.
No, I think you can think about what the other investigators did. They made a vaginal suppository with another lactobacillus strain, and then you come to the place where you have to be. So I think that you can overcome that problem.
And you can't do that with the cranberry concentrate as well?
No, nobody has tried it, but yeah.
Okay, well,
It can be an idea, because the problem is in the bladder.
Yes. The recommendation came here first. Do we have some questions in the room? Anyone? I see some puzzled looks on faces. And nobody on the internet? No. So let's see. What would be the next steps then that are you going to, I mean, you might want to repeat some of these analyses with another set of women if you get information suggesting that the dose was too low. I mean, already from what you've said, it seems as if the dose might be not right, not ideal.
Yes, but it is a prevention method, and the people took 2 capsules per day. And I think if it's only possible to make these capsules, you cannot ask people as a prevention method to take 10 capsules a day. There will be no adherence. So on that side, there must something happen. It will be more concentrated in 1 capsule or something like that.
Right.
So that is the cranberry story. But about the lactobacilli story, we found that in women who had a higher chance for complications of the urinary tract, so the more difficult group of postmenopausal women, that there, if you compare the low-dose antibiotic prophylaxis and the lactobacilli, the working was were equally effective. So I would perform a next trial in that group. So the special group who had more chance for complications, or complicated UTI, and I think then there must be a vaginal suppository. Go where you have to be.
Yes. Okay. Well, I think that might be a good way to sum up your findings, is go where you have to be. We have a question from the internet. Yeah. We have technical problems with the microphone. Okay.
Actually, we have a question from a user who doesn't use Twitter but is watching us online and is on the phone. He is with Urology News, and he has a question, wants to know, for physicians who are treating patients with recurrent UTIs, what is the take-home message of your 2 studies? So
the take-home message for physicians, yes, it's again the same message. I think you must discuss with the patients if they want to try to take the cranberry capsules, but you must also say to them that it's only effective in 1/3 of the patients, and that's only in the younger group. So if you talk about elderly patients or patients with a catheter or in long-term care facilities, then we even don't know, and they're even less effective as far as we know. And of course, you still can prescribe low-dose antimicrobial prophylaxis, but then you must realize that they will develop resistant microorganisms, and when they get a UTI, it will be more difficult to treat it.
Okay. All right. Is your caller satisfied? I'd like somebody who still knows how to use a telephone. That's good. So I've been talking with Suzanne Geerlings of the Academic Medical Center in Amsterdam, the Netherlands, and we've been talking about the use of cranberry encapsulated cranberry concentrate as a preventive material for urinary tract infections. This then will conclude this session of ICAAC Live. There is one more session of ICAAC Live this afternoon at 2 p.m. Pacific Daylight Time, and that will be a special session of This Week in Microbiology, in which Vincent Racaniello and Michael Schmidt will be hosting the session. Tomorrow there will be we plan for 3 more sessions of ICAAC Live, and thanks very much for joining us.
Explore the fundamental role of microbes in the natural history of our planet with Microbes in Evolution, the world that Darwin never saw. Available at estore.asm.org.